everyone. Welcome to the session. This is a panel discussion session titled 30 Years of HIV AIDS. And I'm the moderator of this session. I'm Crystal, and I'm a medical doctor trained in community medicine and also psychiatry. The reason for having this panel discussion is for us to reflect on the challenges and some of the success stories we have in HIV work in Hong Kong in the past, so that we can generate thoughts and insights to inform the work on the next HIV strategies for Hong Kong, and also to support people in the field to achieve the zero HIV new infection by the year 2030, which is a very ambitious goal set by the UNAIDS. With huge efforts, we have had some successes in bringing down new infection, as shown by Dr. Wong this morning. Yet, without far sustained and expanded effort, the epidemic can actually rebound faster than we can ever even know about it. So as you can see, we are very excited to have our other panelists here today with us to share their thoughts from their work for many, many years in Hong Kong. Let me introduce one of them one by one. Professor Joe Lau on the right-hand side. I think he needs no much introduction, as if we have been working in HIV in Hong Kong, we all know him very much. He just told me he started his work on HIV in 1990. He is a prolific researcher in behavioral science and HIV prevention in Hong Kong. And he has served numerous consultancy work, and he is currently the emeritus professor and research professor in the Jockey Club School of Public Health in the Chinese University of Hong Kong. Dr. Ho, who is sitting beside me, has just retired from his 34-year of public services last year. Before his retirement, he was the consultant dermatologist and head of the social hygiene services of the Department of Health, the public service provider for STI and dermatology service in Hong Kong. He coordinated the Universal Antenatal HIV testing program during his secondment to the AIDS unit in the Department of Health. And he has served as member of the Scientific Committee on AIDS and STI in different periods of times. He's currently a very important member in the AIDS Trust Funds, because he's a member of the Medical and Support Services Subcommittee of the AIDS Trust Fund. And Andrew, on the other side, he again probably knows much introduction. He's the chief executive of AIDS Concern in Hong Kong since 2013. Over this period of time, he has worked on the development of AIDS concerns and HIV prevention and support services with the aim to increase community impact and bring innovation to the HIV response in Hong Kong. Recently, he has been working on PrEP, HIV self-testing, and the launch of the place where three of us are sitting now, my place. This is a social enterprise project initiated by the AIDS Concern that provides services to the community, at least for HIV. He has also worked with various partner organizations and HIV projects across the Asia-Pacific region. I'm very glad to have all these panelists with me and with us today from very different backgrounds. And I think that's already made a very important point in any successful health promotion programs. That is the commitment and also the passion of each one of us, and the collaborative work between the community, the public service, and the academic researchers, as well as community participation. So without further ado, let's start our chair discussion today. So we first begin with looking back in the 30 years response of HIV in Hong Kong. Dr. Ho, maybe you can share with us some of your insights and knowledge about what are the key milestones of HIV, the epidemic in Hong Kong?
Yes, I'm going to share these key milestones and or benchmarks in the history of HIV/AIDS in Hong Kong. The first HIV case was reported in 1984 in Hong Kong. And in 1985, the AIDS unit in Queen Elizabeth Hospital began as an AIDS counseling and health education service. In early 90s, the well-known local AIDS unit, the name of the Special Preventive Program, was established in the Department of Health, led by Professor S.S. Lee. And since 1990, SPV has assumed the role of Secretary to the Advisory Council on AIDS, which is in fact established in the same year. That is, Advisory Council on AIDS was established in 1990. And in 1996, the Red Ribbon Center was established in Hong Kong, and the RRC was the designated UN AIDS Collaboration Center for Technical Support in 1998. And these are the important milestones. And in 1999, the Integrated Treatment Center, which is located in Kowloon Bay, was established. And the introduction of the Integrated Treatment Center for care of people with HIV infection have elicited a very strong community response in a negative way, opposition by the local community, which is an important benchmark. And in 1993, the AIDS Trust Fund was established, in fact, by the last Hong Kong governor, Honorable Christopher Francis Patton. And with the introduction and establishment of the AIDS Trust Fund, initially it is provide assistance to HIV infected hemophilians, and then due to strengthen the medical support service, and then to the public education on AIDS. This is a very, very important benchmark because the introduction of ATF. And how about the community? Well, in GIST, Joe will supplement what I say, my observation. A lot of in different time, the committees, say Scientific Committee on AIDS, Scientific Committee on Prevention and Education of AIDS, promotion of acceptance and of people living with HIV/AIDS, and all these committees provide a platform for the community participation, and this in the local HIV/AIDS prevention and care. The AIDS Concern was the first NGO established in Hong Kong in 1990, which is in 1990. The AIDS Concern was established, which is the first NGO with committed to service to AIDS care and then prevention. And it is a very good example of a local example of a multi and participatory community response to HIV/AIDS with participation and contribution by persons from different backgrounds. And I think there's a very important milestone is this is the first the first person living with HIV/AIDS, Dr. Mike Sinclair, a dentist, who openly disclosed his status, calling for positive public response in HIV/AIDS. And regrettably, Dr. Sinclair passed away in 1995. And the RTHA, in fact, is with a record, make a program and obtained a award in the Asia Award, which is a very important milestone that somebody just come out and make it in person and call for the local communities response to HIV/AIDS in Hong Kong. The first AIDS strategy, 1999 to 2001, adopt the community planning process principle. Okay, and then now is the community forum, which is the first local AIDS strategy, which is 1999 to 2001, and the more or less that's the same time in 2001 September, the local universal antenatal screening program was loaded in Hong Kong. Well, the program is an example of multidisciplinary, multi-organization, multi-sectoral engagement and participation. And I would end up here and pass my pass to Joe for his view.
Thank you, KM. We are old people in this area. We worked together for 30 years. And then I would like to comment first on the development of the NGO responses. So the AIDS Trust Fund, the AIDS Foundation and the AIDS concern was established in 90 and 91. And then the AIDS Trust Fund, as said, is 93. That means a lot of NGO was set up around that time because they could obtain funding. And then this at that time it's very easy to set up an NGO. You can be a one-man band, and then in 1 or 2 weeks, and then you obtain a small grant, and then you can. So thus at that time, a coalition of NGOs were formed, including Teen AIDS, Society for AIDS Care, and then later on Action for Reach Out and Choice, etc. Right, and they form a CASO, a coalition of AIDS services in Hong Kong, and that actually was in charge of the community planning process. So the interesting thing is that we have quite a lot of small NGOs, and the second wave is under a special MSM funding, which I will mention, and then other NGOs more specific in MSM work, like Rainbow or AIDS Backup, were set up together with the participation of some mainstream NGOs, right, like even BGCA, etc. So we have many NGOs, and the strength is that they can work from different angles. The difficulty is that they often, the economies of scale has been difficult to establish. And then even we have the coalition, except for the community planning process, was quite unable to integrate the services, although there's a lot of sharing. So this is one feature of the NGOs in Hong Kong. Then I briefly introduced the milestones in the interventions. In the interventions, I would say there are a few phases. The first phase is education, and then just people do not know what HIV is, so it's a lot of misconceptions. You can see under the ACA that the committee is called Committee for Publicity and Education in AIDS, right? So the activities would be a lot of advertisements. I made one of them. I suggest anyway. Jackie Chan, and you remember a lot of these advertisements and TV activities. But then it's not significant adequate to just to have education is recognized. So it's mentioned that the second phase is the community planning process following the US model to gather information about the risk situations in Hong Kong. And the report was given to Margaret Chan then. And then it has an impact on the HIV field because, as said, the AIDS Trust Fund and the ACA adopts the approach. And then the interventions now has to focus on risk group instead of very general, like basketball game and all those general education activities, right? So the third milestone is the Dr. Tim Brown's modeling report about the risk and size of the epidemic among MSM, okay? And then the government was responsive. They set up a special MSM funding. As I said, that is the reason of the increase in MSM work in NGO in very different angles, from different angles. The fourth milestone, I would say, would be the treatment and prevention cascade coming out, and people see prevention, biomedical prevention, treatment would be very effective for prevention. And the government has been doing very well on some of the cascade on treatment side. And then it highlights the gap would be on the testing side. And a lot of effort, hence, more targeted to testing, especially in the MSM community. It's ongoing. The fifth wave milestone, I would say, is the start of the discussion of PrEP, right? And then it's still ongoing. It's a bit slow, as we will discuss more, but it's ongoing. And people have now put more emphasis and effort and hope and discussion with the government. So I'll finish here. I just hope that this gives you an overview of how the NGOs were formed and the changes in the emphasis of interventions. Of course, this is one of the personal interpretation of the scenario. Okay, I'll hand it back to Crystal.
Yeah. So thanks, Joe and Dr. Ho, for giving us a very concise overview of the development of Hong Kong HIV prevention work in the past 30 years. So how about Andrew, as really the field worker, what are some of your reflections about your HIV work or HIV prevention in Hong Kong?
Thank you, Crystal. Well, I think if we go back to the early 1990s, we can remember that HIV/AIDS at that time was a death sentence. People were getting very sick and they were dying, and it was a scary time. And we didn't have good treatment options available for people. So when AIDS Concern was set up in 1990, what the agency was trying to do was to provide support that it could to people with HIV/AIDS and their families. The situation was a very stigmatized one. Families were rejecting people living with HIV. They were afraid and fearful of this virus, and it was a very stigmatized virus. So it was a difficult time to be living with HIV. And the sort of work that AIDS Concern was doing was really providing practical and emotional help to people who were dying of HIV/AIDS. And so we as an agency were delivering food to people. We were helping them with their clothing laundry and things like this, talking to them, visiting them, because often family had just deserted them. So I think it was a very different time. And then, as just been described, came treatment options, and things have started to change a lot. So as we know from the last session, people are now able to live well with HIV when they're on treatment. So in that time, you've seen a big change in the way that NGOs operate. So rather than doing things like offering a hotline to people with HIV who are panicked about having a diagnosis, AIDS Concern now does a lot more work in the area of prevention, education in the community, helping people understand how to prevent HIV, what are the combination prevention options, but also providing HIV testing through our centre and other means, and also giving some emotional and practical support to people living with HIV. So I think the main observation I want to make about the history is the changing role of NGOs that's been changing to reflect the needs of the community in the epidemic. And I'll just give two very quick examples. One is on testing. As testing technology has been developing, we've been looking to see how can we make it available to the community. And we began piloting with the Chinese university self-testing in 2016 and seeing was it acceptable to the community following the World Health Organization's guidelines. We found that it was acceptable, it worked very well, and also it brings in people who never test normally, or people who often don't test often enough. So this was an important change, self-testing, and now we've been rolling out self-testing. Another big change, as Joe described, is PrEP. So AIDS Concern and other NGOs have been educating the community about PrEP and how it can work. We now need to understand how can we make sure that it's implemented so more people can access it. So this is the changing nature of the role of NGOs, which is reflecting the changing epidemic, but also the changing interventions that we have.
Thank you, Andrew, for your thoughts about HIV prevention work in Hong Kong. So from what I heard from all of you, I think there has been success in HIV prevention, definitely. We're seeing like a significant, about 20% drop of HIV cases among MSM over the last 6 or 7 years. So I think the important elements that Hong Kong have is a very strong commitment from the government, strong surveillance, epidemiology, AIDS trust fund that facilitate community response, et cetera, et cetera. And also we have excellent HIV treatment so that we can achieve a good control of viral load in the community among the HIV infected individuals. Of course, strong community participation is always a key element in successful health promotion in HIV prevention. But then what I just heard from all of you is that we have Dr. Mike back in 1990 to come up as the first person to speak up and to call for like positive response from the community about this issue. Like over the many years, we don't see another one, right? We don't see people with HIV coming up to talk about their experiences, despite the number have been, I'm sure, has been escalated to over 10,000. Infected people in Hong Kong. I mean, the numbers of patients are increasing, but they don't come up and talk about it in the community. That's one point that I just heard from the discussion. And apart from that, so with all these efforts, we are still seeing, on average, I think around 8 infections or reports every week. And infection numbers are still ongoing. So most of them would be MSM, and a number of them are still heterosexual, male and female. So what are the challenges we are facing if we want to further reduce these numbers in Hong Kong? So maybe Andrew, you can go first. What are some of your thoughts that we should be doing so to further reduce the numbers?
Well, I think to comment on your point about there aren't many people with HIV speaking out, Crystal, I think it's very noticeable that compared to some other countries where there is a lot of work on HIV, there are very few people with HIV in Hong Kong who feel comfortable to speak out about it. And I think this is an important factor for us to understand in developing our interventions and responses. We can do more to encourage and support people with HIV to speak out. But I think the truth is in Hong Kong, HIV and this health issue remains very stigmatized, and people aren't comfortable to be seen as a poster person for HIV prevention work. And often it's their families telling them, even when we've had people who are saying, I might be willing to do something, often their families will say, oh, please don't do that. It will bring attention to our family, and we really don't want that about this issue. It's to do with stigma. So I think this is a very particular, it happens in many parts of Asia, but I feel it's particularly strong in Hong Kong. I think one of the big challenges, apart from stigma, is making HIV relevant and understood to the younger generation. So if you look at, for example, the key group of MSM, lots of older MSM in their 40s, 50s and above very well understand the AIDS panic in the 1980s and 90s and are aware at least of HIV and what some of the things they should be doing. The younger generation, in their teens, 20s, into the 30s for some, aren't necessarily as aware of the risk and the threat. And of course, if they do learn more about it, they learn that there is now treatment available. So it's a different risk for them, and they need to understand it. So we need to work to make sure that younger people understand the risk. Testing rates have risen, but there are still groups of people who are not testing, who are high risk, and people who are high risk and test, but don't test very often. So this is what we find when people with HIV are diagnosed. Some of them might have tested 2 years ago, and they might have had HIV for 6 months, a year, and they haven't tested. So offering people different types of testing options, different locations, HIV self-testing. Self-sampling is another option where people take a sample and send it off to have somebody in a lab do the diagnosis work. This has been used successfully in some countries. We can look at that as well. The other thing, one issue I was going to mention is the use of crystal methamphetamine. If you go back 10 or 15 years, there wasn't nearly as much of this among MSM in Hong Kong, but it has grown since then. And we know that often when people are using crystal meth, that the level of protection they use, their condom use drops. So we need to make sure people understand crystal meth and the risks of HIV transmission and how they can prevent it. So these are some of the challenges I wanted to mention.
Thank you, Andrew, for your insights. How about Dr. Ho? You have worked in the AIDS Trust Fund, right? So you have seen projects submitting for services and prevention. So what do you think are some of the challenges that you see in further expanding our efforts in HIV prevention in Hong Kong?
Well, from what I observed from the applications to the AIDS Trust Fund in the past 5 to 6 years, there's a few observations. The observation is, as we communicate with Joe, there's quite a number of NGO, including academic institutions. But even within the same academic institutions, to Unit A, I think to say the Service Department A does not actually speak to Department B within the same university. And in fact, they are doing more or less the same things with the same focus, not the same things. Well, maybe one is more focused on the behavioral side, the other is the behavioral side together with some of the treatment side, with a slightly very different, objective of study, and they found separate projects. But if they combine together and to work a single project with in fact, it's more money, slightly more money, then the result may be more better and cost effective. But from the perspective of the funding agency, we have only A and B's. Okay, well, one is score 85, the other is score 80. It is very difficult for the funding agencies to grant funds to both. Okay, we have to sacrifice sacrifice one of them. But maybe the other, they score the project with 80. They have something very supplement. Is something the result may supplements the deficiency of the project A. And this is one of the important observations. Same observation happens to the application from the other NGOs. As Joe said, the small NGOs, they do a small project, big NGO, but there's many overlaps. Not really very coordinated. Some hot topics, they have many projects, but there are some more important but more difficult to do area. So nobody is interested to send project applications to the so-called forgotten or important but difficult to do areas in the field. Therefore, this is one of the observation, and this is one thing. Coming back to the testing, we have from the perspective of previous government officer, we want to see is there's in fact a lots of different ways, a myriad of testing in terms of testing mode is a fingerprint, blood testing, oral fluid, government venue, NGO venue, self-testings, and even some of the different testing models, such as this is not exactly testing, but some kind of screening or a screening model. But it is also fulfill the purpose the function of testing is our model is not just doing testing for resident clinic users, and the antenatal setting is an optimal testing model. And this is very good. But the observation is no matter what we did, the testing rate, the ever testing rate is something like 80%. And they say that according to the Harris published in 2000, conducted in 2020, and about only 60% tested in recent 1 year, as Andrew pointed out. There is still a big gap in the most optimum to in enhancing big gap in testing, and the questions this is some hidden, we don't know. It is not definite evidence based. If those who opt not to test, maybe those who have the highest risk, we don't know. Okay, this is something that we need to know and need to enhance. And for CAM fund, it is a very difficult area, very difficult area to go in. And I think there's not too many interventional, not survey, but interventional projects received from the ATF. Not too many. It is intervention. I mean intervention, not surveillance. Surveillance is lots of surveillance. No, but how to intervention, good project, good project intervention project. There's not too many. This is what I observed.
Thank you very much, Dr. Ho. So the interesting point in Hong Kong is that we have individuals, academic, we have individuals, NGOs, but then how
not
we
very
can,
coordinated.
yeah. The issue is how we can actually put it into very cost-effective or very effective way to make even bigger prevention efforts in the community.
In fact, more cost-effective.
Yes.
Especially in nowadays we have difficult in sustaining the funding.
Exactly.
Yeah.
Difficult to sustain funding. I thought difficult to sustain the people also.
Oh, yes, right. Yes.
Because people goes with the money. The work goes with the money also. Okay. So Joe, you worked in the field as the application for the ATF and also support all the NGOs development.
Okay.
So
I'd like to ask Joe. Okay, what's the difficulty for you to communicate with the other department?
There's no difficulty, but there's no culture as well. There's not really
culture, right?
And then you have to understand that people are usually very, very busy. When they think about one thing, they don't know what's the mind of the other. Well, I don't want to focus too much time on this. I think I agree with you more. Cooperations are always desirable. Okay. And then the other positive suggestion is that the AIDS Trust Fund can also do something. If there's something good, you can suggest the 85 scored team to talk a little bit with the 80 to consider that part instead of just chopping it off, right? And then I think something happens and something, but this is not I think that we're not going into spending too much time on this. The NGOs are also these integrations. I think it's more important than the academic field as well because they are the frontliners, right? And then, let me talk about other observations and challenges, which is maybe controversial and politically, I don't know whether it's correct. But as you said, KM. The behavioral change is not very evident in the HIV, right? Condom use, and then even testing. 2/3. It has been like 15 years. It's about around.
Which is although it's slightly up and down in recent years, maybe a little bit decline, but overall
not what we would like to see, right?
Yeah.
And then, when we compare to other public health work like smoking or cancer screening, you spend that much effort in 20 years, you expect something more, right? But so the conclusion is that behavioral change is not happening. If we want to analyze, it's difficult, but there's a message fatigue. People have been talking about the same thing, wear a condom and the things, right? And then the NGO seems now to be a bit stepping back from the behavioral change approach and relying more on the biomedical approach like PAP or something like that, right? So if we review the programs, there might be not a lot of effective behavioral change programs being planned or implemented. But from the other perspective, I would like to discuss about the personal responsibility, the responsibility of being healthy. Like in COVID-19, we wear masks not only because of the law or something. We also want to protect ourselves and protect others. I'm quite sure, right? And then so I think the community needs to consider whether there's a personal responsibility to use condom and to get tested, but there's no norm. Wearing a mask is has been a norm, but there's no norm in the community, in some of the key populations. No norm that you multiple sex partners or condom use. There's no norm what people should do or quite right. So and this sometimes we can, like second smoking, we were quite able. Public health people are quite able to establish and change the norm. You should not smoke in front of others, okay? But the difficulty might be there's not, as we previously discussed, there's not easily an accessible intake community in MSM or other communities, key populations that have a very key good participations and accessibility to work with the HIV workers to see whether there's any possibility to change the norm a little bit. If the norm is not changed, testing behavior would be 2/3 or something. The NGOs try so hard, right? So this is just one perspective. I won't overrun, and so I think the community work and this aspect needs to be considered as well.
Yes. That is the problem of engaging, and actually engaging the so-called the community people, engaging MSM, especially the KOL in MSM, actually to take part and take an active part and frontline part, in front, to engage in changing the culture. Changing the culture,
it's maybe especially important for young MSM when they get started. What is the norm? The norm is that everyone use, everyone not use, or something. This is a long procedure, but if the norm is not changed, the behavior is not changed, we can only rely on biomedical interventions, which is a long way to go.
Sorry to say that I'm not provocative. I tend not to provocative. That means, for instance, for sex workers, the NGO workers is a lot of good participations and active participation, but there is not too many sex workers themselves to actually engage in the project. MSM also apply to MSM. The drug users, there are too many, very few drug users. They are drug users themselves or ex-drug users themselves to actually engage to change the norm and participate in this project.
We're off the script, but very brief. Well, female sex workers actually do have a law. Right? That you should use. They want them. Sex workers would like to use, and clients would like to use condom. Or if you don't use it, you're away from the law somehow. So actually, the condom use within the sex workers and clients are very high in Hong Kong. I just point out something from thought.
That is, you need to have this kind of active participation to make a cultural change, to create the norm. Okay, this is I think this is what Joe.
Andrew might be very.
Facilitators.
We're off the script now.
I agree with some of it, but I don't think I agree with all of it. I mean, I think it's true that there is. Of course, we always in public health want to see stronger community norms that reflect public health messages, which are based on evidence. So, of course, there's always a gap. There's always a gap between what people are doing as a whole and where we want them to be. And in cases of some medical conditions like COVID, we've seen that the gap is less, but that's been with very, very strict enforcement and massive investment in education campaigns and so on. I think what we can see on HIV is that actually a lot of the community is following the public health norm that we want, but of course not enough of them are doing it. So a lot of MSM are using condoms. A lot of heterosexual men with multiple partners are using condoms. There are lots of MSM coming to NGOs asking about PrEP. How can I get PrEP? How can I use it to protect myself? So I think some people are doing it. The issue is really much more to do with the scale and how can we get more of them to do it. And I think what we're finding is that we have a whole range of different interventions that people can choose from to protect themselves. And we really need to make sure that people can find the ones that are suitable for them. Some people don't want to use condoms. They don't like it, or it's not convenient for them. So maybe they can use PrEP. Other people, I've got a visitor here. Other people, don't want to go to a clinic to do HIV testing. And so we can find other options for them. They can send a sample back. They can do a self-test. So I think this is part of what we need to do in the next stage of the response. I don't think we're giving up on condoms and other interventions. I think we still need to state those and make sure they're accessible to people. But when we have new interventions available for people, we need to help make them available. I mean, on PrEP, I mean, I was listening to Dr. Wong Kar Hing talking about where they might go next. And I think what we need to do is to see how different sectors can work together on PrEP. I think it doesn't work often for the government services to be educating the community about some of these interventions in terms of community campaigns. I think it works within services, but often people don't want to go and hear it from the government services. They're wanting to contact NGOs and others because it's very stigmatized. So I think NGOs can do work on educating the community about what PrEP is, but I think we need some help from the government to open access to PrEP medicine and support by either integrating it into the public health system or finding a way to develop a partnership between social hygiene clinics, NGOs, and maybe some other private providers so that people can access PrEP. I think we've got a lot of evidence now about PrEP that we just need to find a way to fund it and roll it out. Maybe I'll stop there.
Okay. Thank you, Andrew. Yeah. So we probably had a lot of challenges, huh?
Yes,
if we need to further reduce the new infection really to like sort of close to zero in a number of years to come. Just to summarize, I think the challenges is that we need to balance availability of a combination of prevention that could be accessible and acceptable to the community. So we shouldn't be focused on just one of them, condoms or PrEP, but the availability of things that are suitable for the community. And I think we talk about stigma and sexuality of the younger generation. That would also be another, I think, an important area that we should work on. Because I think, for example, in my experience working with those with chemsex, some of them may have issues with mental health issues. Some of them will have issues with being in a non-healthy relationships. They may not be able to see the sexuality. They don't feel loved. There are some of these issues that we need to tackle in the sexual minority group, I would say. And that will start from sexual education in the youth or even parental education. So probably we don't have much time. Looking forward, let's move on. So I think it's actually very difficult to really get to know HIV infection in 8 years' time, but at least we should have some targets to move forward to. And and there are many things we need to do. How should we prioritize on what we need to do go forward? So maybe Dr. Ho, you have any views how we can make better collaborations, etc.
Okay. Before I go to the collaboration side, well, something that I think I missed in the very initially, and nobody here have mentioned is the HIV prevention in the ethnic minority in Hong Kong. Okay, it's another very challenging and I think as a important piece in the jigsaw puzzle. Okay, it's the ethnic minority, and this is I need to raise up in this in this meeting. And in terms of collaboration and cooperation, before I have nothing that which is a very urge to say, but I would like to invite Joe to share his experience. He derived from when he is a chairman of CASO. What is your observation and what do you think that may be useful to improve the communication first among the NGOs? Okay, this is one thing. And as a chairman of the CASO, you represent, in quotation, you represent the NGO. The better way to communicate with the government. And this is your experience is very important.
I was only the second term chairman, okay, no longer now, right? And I was in charge with Graham Smith, the community planning process. I think it's always difficult because the inherent unspoken type of competitions over the same thing. And because of this, as you said, the NGOs are not large size, and they could only work on something very immediate, very manageable, right? And they could not plan a large. So I think it's both ways.
How do you better coordinate the effort of the NGOs?
Yeah, I think the government can put forth some commissions and some funding requests for large-scale collaborative research. I'll give you an example, testing, okay? The government might consider, okay, you NGOs come up with a joint proposal about how to increase testing in a very comprehensive and with division of labor, who do what in what group, as you said, ethics minorities, one NGO and some, and so that under one specific, we don't have a lot of things to tackle. Testing is one of them. A special funding, as it happened, it was very influential. And then they have to work together.
Then how to, Joe? But then how to put how to apportion, on the one side, community participation is very, very important. On the other side, you ask for to hand over, in quotation, hand over the leadership to the government side to direct the way to go, and how to make the balance between the two.
I would not use the word direct because it's just a call for proposal type of thing, a theme, and then the council under this theme they will work among themselves, right, to come up with a sensible proposals because they have to work together in order to win-win, in order to win and win-win, right? And then they would start the conversations and what are you doing? What are we doing? Because they have a common aim. Now it's not. Now I can got this part and then I can survive. If I don't do that, I would disappear. Just one suggestion, because HIV is now we can easily come up with a few things, which is a priority. You can follow the A strategy plan or something. Testing is obviously, as you said, there's the gap for the cascade.
Andrew, any thoughts about what Joe has suggested, like the funded call for collaborative projects?
I think that's what would be required to make it happen. I mean, I think it's having a collaborative funding platform or proposal would require the collaboration to be done in a more systematic way. I mean, already the NGOs, the NGOs we have, there are not very many actually. There are only 3 HIV NGOs really. One concentrates very much on care and 2 concentrate on prevention. I think there could be more collaboration across them, but there is already some demarcation of responsibilities that are a bit different, and some of the communities targeted different. The other HIV projects are really projects within other organisations, not those 3. So they're HIV projects that are part of other educational support campaigns. But those organisations might also be attracted to a collaborative approach. I've suggested in years gone by that we should consider merging some of the HIV NGOs, or at least having some stronger collaborations in some areas. But I appreciate it's sometimes very difficult to get those things to happen. But I think, yes, I think we have to look for routes to collaboration.
Yeah. So very briefly, during the SARS period, there's also some grants commissioned by the government that requires 2 universities to work together. And this is there's one possibility.
This is the commission grant. The commission as a designated amount of money commissions to the university, call the university and commission to the university to do some kind of project research. And one thing, very briefly, is do you mean that the funding agency, say the ATF, should apportion the amount of money? Say that you have the priority setting, priority setting in the community planning, the community forum, the community planning process. Do you mean that the funding agency should say apportion 20% of money is focused on MSM, and of the 20% of the money is focused on out of this 20%, 40% is testing and 60%. Do you mean that the funding agency should do that? And if it is the case, then the questions comes up is whether the apportioning of the funding, the apportioning of the funding to the NGO, could it be can the apportioning, the decisions acceptable to the individual NGO? How to engage their support?
Yes.
For such
the community planning process was meant to be a purpose, but that was 2 decades ago already. We have to update such processes.
Yes.
But I think if we identify certain issues like testing, and the AIDS Trust Fund has a sizable. I don't think we are saying to use it all up but say okay, this year we of course there's some preparations. Okay, how much is needed if we want to? The NGO has to pledge. This NGO pledge, I'll do 10,000 testing. Okay, and this how many? And okay, so if you want to say, this year I would like to see how many 30,000 testing more, right? Then you can roughly think out how much that would mean, right? So it's a target thing. You don't need to allocate everything or on that basis, okay? But MSM testing is a priority, right? So if how much money you discuss with the community, how much money AIDS Trust Fund can allocate as a special fund or a pilot for collaborations. This is a possibility for people to consider.
I agree. I would say just my final comment would be, I think that testing collaboration is an opportunity. I also think PrEP collaboration is a big opportunity. And I don't just mean between NGOs, I mean between the public health system and NGOs. So I think this is the other thing that we need to look very carefully at, because it's difficult for HIV services in the public health system to allocate new resources. I understand this. But I think that there isn't a way that we can look for collaboration across the public health system and the NGO system to educate and provide PrEP for people. So I think if we're thinking about the HIV/AIDS strategy in 2030, getting to zero, I think these are 2 really important things we can do.
Maybe all in all, PrEP is the most important thing that we need to work together. Right? Testing, we know how to do. It's just not enough. But PrEP is the question of how to do it, and it has been hesitant for years. The government, right? It's now really time for action. Right? And then I think this is a good collaborative work. We have to sort out what are the key issues. Right? Is it because of course a co-payment model or whatever? And there's no perfect solution. The community and the government find some agreeable thing, and it's not once for all. Well, we need the government might think of a real, quite large scale first phase or pilot, whatever we call it, right? And then we can adjust after 2 or 3 years about all this. But if we're hesitant, that we have the NGOs have been doing all they could.
I think so. Yes. We all agree that PrEP is one thing we need to really focus on. And at this point, I just want to raise a point is that we need strategic advocacy work to make things happen. So in the past, I remember when I was in the government, we can actually liaise with influential people like the legislators in the past, people who are speak up in the community to make changes. Sometimes people move because they have to answer questions in certain platform. So I would again just the last point I want to make is that we keep up our strategic advocacy work from all parts of people in Hong Kong, and we should keep up our good work in the past, and we should focus on collaboration, integration of services, and also targeting all the stigma and also the societal factors that affect HIV in Hong Kong. And with these, I hope we can work towards the goal of further reducing HIV new infection in Hong Kong in a few years to come. I think time is about that. Andrew, do you have any last word to share?
I just wish to say thank you to Crystal and Kingman, and also to Joe for this really excellent and insightful panel discussion, which I think gives us a lot of thoughts about how we can create HIV response, learning from the past and also understanding the challenges of the present. So I think we're recording this session and we can share it with other people who I think will benefit from hearing your insights. I think we'll close the session now. It's time for lunch. Thank you. It's time for lunch. So we're on lunch until 2 p.m. At 2 p.m. we'll be having an update on PrEP from Dr. Heather Marie Schmidt, who is from UNAIDS. And then we'll hear from Mr. K.B. Lee from AIDS Concern. And then we'll also be hearing in the afternoon from Dr. Winston Goh about the important topic of rainbow health in Hong Kong. So thank you, everybody, for the sessions this morning. And we look forward to seeing participants in the afternoon. Thank you. Goodbye for now.
Okay, Andrew, stay. Let's take a screen capture on a photo. Screen capture a photo. Yes, okay, yeah.
Can anyone help us to take the
screen capture?
Tim, has it been done? You've been smiling for a long time, can't you?
I just did one, so we've got one.
Oh, that's good.
Okay, yeah,
okay,
thank you.
Thank you, everybody.
Okay, bye.
Okay.